Good evening, everyone. Welcome to the Sri Lanka College of Internal Medicine second expert committee webinar for year 2025. Today, we are going to have webinar from the toxicology expert team. I'm Dr. Avi Jayawardhan, member of toxicology expert team. As you all are aware, the bees and host visitings are not uncommon in Sri Lanka. We come across a lot of patients with bees and host visitings every day. Most of the cases we manage without any problem. But when these patients develop complications, it is very difficult to manage, and sometimes these patients die. You may not aware, annually there are 12 to 15 patients die following these stings. These experts in this field are very rare, but fortunately, Sri Lanka College of Internal Medicine Toxicology Expert Committee has expert on this field. He has done a lot of research, and today he's going to talk the hidden danger of Hymenoptera stings. Before introduction to the today's speaker, let me invite President Sri Lanka College of Internal Medicine, Dr. Trishanta Jayasekara, to address the gathering.
Thank you very much, Ravi. I think Sri Lanka College of Internal Medicine has 6 expert committees, namely NCD, infectious diseases, acute care, toxicology, humane care, and scientific research. So we base our most of the academic activities through these 6 expert committees. And today, so we are showcasing our local talent on various aspects of toxicology, toxicology clinical scenarios. So we have mainly three things that we discuss under toxicology. One is snake bites, then we have poisoning, and thirdly we have this bites and stings. So we have listened to many snake bite and poisoning lectures, but this is a rare occurrence that we listen to this very important topic. As Ravi very correctly said, we see many patients with multi-organ involvement following stings and bites. So without further ado, while welcoming everyone, actually the physicians, trainees, and all the medical officers who have joined today, let me invite Dr. Ravi Jayawardhan to introduce the speaker and proceed with the webinar. Over to you, Ravi.
Thank you very much, sir, for your kind words. There are a few housekeeping rules that you have to follow. Please keep your microphone off during the lecture. Your questions will be taken up after the lecture and during the Q&A sessions. You can type and send your questions from chat box. You can claim CPD points for your attendance today. For that, you have to fill the Google form. That is Google link. For the Google link, there is a QR code. We will display it after the lecture. You can scan the QR code and fill the Google form. Then we can send your e-certificate within 2 weeks. Please fill this, scan and fill this Google form. Without further ado, I'll introduce today's presenter. It's my honor to introduce Dr. Rohitha Amara, a consultant general physician and specialist in internal medicine. Dr. Witharana graduated with his MBBS from the University of Peradeniya in 1999. He obtained his MD from the University of Colombo. He is currently serving as consultant physician at the base hospital Gampal. Dr. Witharana has an extensive clinical and academic career spanning multiple hospitals in Sri Lanka and internationally, including his valuable service as a lieutenant colonel and peacekeeping officer with the United Nations mission in South Sudan. He has received numerous accolades for his innovative research, particularly in clinical immunology and tropical medicine. His focus area of research on Hymenoptera envenoming stands out as a crucial contribution to our understanding of this neglected tropical disorder in Sri Lanka. He has presented widely on this topic, including the prestigious Professor K. Rajasuri Memorial Oration in 2022. Please join me welcoming Dr. Witharana as he present on the hidden dangers of Hymenoptera stings, shedding light on an often overlooked but significant health hazard in Sri Lanka. Over to you, Dr. Witharana.
Good evening, everybody. First of all, I would like to thank the President, Dr. Krishant Jayasekara, and the Council for inviting me and giving me this valuable opportunity to talk to you on Hymenoptera sting envenoming, bee, wasp, and ant sting. So, let me to start my presentation today. The topic is From Sting to Fatality, the Hidden Dangers of Hymenoptera. No conflicts of interest to declare for this presentation. And this presentation outlines 3 case scenarios of severe envenoming after bee sting, the burden of the disease in Sri Lanka, epidemiology, clinical evaluation, and management of Hymenoptera envenoming in this country, the main challenges of management of Hymenoptera envenoming in Sri Lanka, and finally, key takeaways. Let me start the first case. My patient was a victim of atypical reaction after giant Asian honeybee sting. Patient was 65-year-old farmer. He presented to base hospital Deniaya, where I worked few years ago, and he presented with mass envenoming or mass stinging event. Patient was stung by giant Asian honeybee. The insect is Bambara bee, and presented to our hospital in the morning. We treated for the severe allergic reactions was there, but blood pressure was normal, not much tachycardic, generalized edema, and erythematous rashes all over the body. And he was stung by more than 500 bees. So we treated, and patient was recovering. However, same day in the night, patient complained he had difficulty in walking. So then we examined again patient and noted the left lower limb was cold and there were no pulses in the lower limb. So it's very pretty obvious it is a case of arterial thrombosis is the clinical diagnosis. So we have no resources in this hospital, base hospital, just upgraded few years ago, 10 years ago. And then I discussed immediately with the uh, vascular team and casualty medical team of NHSL, and they accepted our patient and asked to transfer. So we heparinized patient and immediately transfer. It was for 3-hour journey from Denia to NHSL. Anyway, immediately they did of the lower limb and confirmed there was a thrombus in femoral artery. Did thrombectomy and remove the thrombus and save this patient's lower limb. So this is a case of arterial thrombus, femoral thrombus after BT. This case we published in BMC research notes as giant honeybee, Apis dorsata acute limb ischemia report and review of the literature. This is the first reported case of femoral arterial thrombosis after BST. Let me discuss my case. A patient, 75-year-old lady who had bronchial asthma and hypertension presented to ETU, base hospital Gampola, where I work now. Few months ago, patient admitted to our ward. After an attack of a swarm of bees, she had drowsiness, itching, facial puffiness, generalized edema, difficulty in breathing, mild chest discomfort. She was stung by more than 250 bees while she was plucking tea leaves. It is obvious the patient is having symptoms of severe allergy. Examination revealed stingers on the skin, generalized edema, urticarial rash. GCS 14 out of 15. Blood pressure was low, 72 by 43. She was tachycardic and tachypneic. Saturation was 91. And bilateral bronchi were not. So this is very obvious. The case of severe anaphylaxis after bee sting. So the diagnosis is not difficult. So severe anaphylaxis after sting. So management, everybody familiar in this audience. So we start a stabilization of patient in ABCD approach. We start monitoring IV fluids, oxygen, etc. And we start removing stingers, and at the same time, we start specific treatment for anaphylactic shock. So IM adrenaline, IV hydrocortisone, periton nebulization, and the modality of treatment we started. Right. So patient was recovering with anaphylaxis, and anyway, once patients come to the ETU, we have taken ECG from the patient after admission to the ETU. You can see this ECG. So what are the abnormalities in this ECG? So if you clearly see this ECG, you can see ST elevations all over the most of the leads. So this is a case of ST elevation on ECG other than acute infarction. So it's can cause allergic reactions, can cause uh, uh, allergic reactions, can cause ST segment elevation. So what are the abnormalities noted in this ECG? So, and what is the diagnosis? So this is ST elevation in most leads of ECG, and diagnosis is Cooney syndrome or acute coronary syndrome secondary to allergic reaction. If you see carefully, so ECG changes, ST elevations, you can see in most leads, not confined to a particular artery of the coronary artery. So this generalized, ST elevation, so that indicate most likely coronary artery. So we have taken this ECG after our initial treatment for the anaphylaxis, and ECG, you can see it was normal, and ST segment elevation disappeared. So the treatment is treat for the anaphylaxis and treat for the allergic reactions. Right. So let me to discuss what is Cooney syndrome. It is um, it is common with allergic reaction, but we have not diagnosed frequently. So Cooney syndrome is occurrence of acute coronary syndrome, including coronary spasm, myocardial infarctions, and stent thrombosis, with conditions associated with mast cell and platelet activation in the setting of allergic or hypersensitivity reactions or insults. So simply I can say this is acute coronary syndrome or ischemic events of myocardium secondary to allergic reaction. This syndrome first described by Kunis and Sauras in 1991 as an allergic angina syndrome. So what are the types? Later on, we can see when we review medical literature, a lot of case reports published, and we now categorize into three variants. So type 1, type 2, and type 3 Kunis syndrome. What is type 1 Kunis syndrome? Type 1 Kunis syndrome, we can see patients who has no pre-existing coronary artery disease, and there is coronary artery spasm. So that is the case what we discussed earlier. So ST elevation, we will see he has no the pre-existing coronary artery disease. So that is type 1 Kunis syndrome. Type 2 the Kunis syndrome is seen in patients who has pre-existing atherosclerotic disease and come with ECG changes after severe allergic reaction causing plaque erosions, plaque rupture, or thrombosis. That is type 2, the Kunis syndrome. What is type 3 variant? So type 3 variant is patients who present with pre-existing coronary artery disease and stent thrombosis. So those are the three types of Cooney syndrome according to the current classification. So you can see this picture diagram, and there are three types. Type 1, you can see coronary artery spasm, that is called type 1 Cooney syndrome. Type 2, you can see atherosclerotic plaques with thrombus formation or spasm. You can get sometimes erosion of the ruptured the plaques. So that is type 2 coronary, the Cooney syndrome. And type 3 is stenosis or restenosis or the thrombus in the stent. So those are the three types of this syndrome. It is mostly due to because of activation of inflammatory cascade due to allergic reaction and causing different types of pathology in coronary vessels causing Cooney syndrome. So this diagram very clearly represents the types. So Cooney syndrome. So we use different terms for the Cooney syndrome. It's a vasospastic allergic angina, allergic myocardial infarction, then stent thrombosis with occluding thrombus. Those are the terms we use for the Cooney syndrome. And Cooney syndrome, it is very important. Cooney syndrome seems to be not a rare disease, but an infrequently diagnosed clinical entity. For an I start my work here in Gampala's hospital. We are getting a lot of patients with the bee sting, and up to now we diagnose 5 cases of Cooney syndrome. So actually this is not rare, but it is infrequently diagnosed clinical entity. This is very important. And the Cooney syndrome is caused by inflammatory mediators such as histamine, platelet activating factors, arachnoid acid products, neutral proteases, then the cytokines and chemokines released during this allergic reaction. So this is the basic pathology, and it induces coronary vasoconstriction, activate platelets, thrombosis, plaque erosions, and plaque rupture, end up with myocardial damage. So that is the basic pathology. And what are the ECG changes you can see in patients who presented with Cooney syndrome? So ECG changes, you can see ST segment elevation, ST depression, and different types of cardiac arrhythmias also are possible. So we discuss our case the ST elevation. And again, very important statement here, a high index of suspicion regarding this syndrome is of paramount importance for the diagnosis and treat to the patient. So high index of suspicion is very important come to the diagnosis. And measuring serum tryptase, histamine, cardiac enzymes, cardiac troponin are particularly very useful, investigations to confirm that is allergic reaction as well as there is myocardial injury as well. So this is also very important. Just see, drugs admitted to treat the cardiac manifestation due to Cooney syndrome can worsen the allergic reaction. You know that example, we treat cardiac manifestations of allergic reactions, we treat for the allergic reactions that can worsen the cardiac symptoms. On the other hand, drugs given to treat the allergic symptoms can aggravate the cardiac functions. New drugs for the cardiac symptoms, example, beta blockers for this ischemic, it can worsen the allergic manifestations. So very important. So the allergic treatment can worsen cardiac manifestation, and the ischemic treatment can worsen the allergic manifestation. We'll discuss in the next slide. So the management of this Cooney syndrome, the treat to the allergic event. So with IV hydrocortisone, IV histamine, ranitidine, vasodilators such as calcium channel blockers and nitrates are very useful mode of treatment for the type 1 bronchospasm, the coronary artery spasm, and it relieves with the treatment of allergic reaction, you can see our patient respond well to treatment for the allergic reaction. And then type 2 Cooney syndrome, we have to start ACS protocol together with corticosteroid, antihistamine, vasodilators. Keep in mind, beta blockers and adrenaline can exaggerate coronary stress. So we have to be very careful. Beta blockers usually contraindicated, and adrenaline sometimes we have to use very slowly because allergic reaction, anaphylactic shock is there. So treatment is adrenaline. So that treatment can cause coronary artery spasm. Also advised to avoid, if possible, morphine, because morphine may induce mast cell degranulations, so can worsen the allergic reactions. So very, very important points when you manage Cooney syndrome. So because the allergic treatment can worsen cardiac manifestation, treatment for the cardiac disease can worsen the allergic reaction. So how can you treat for the type 3? Type 3, you have to treat for the acute myocardial infarction protocol should be started together with urgent aspiration of intra-stent thrombus or stent extraction. So we need help from the cath lab and cardiologist, and they will help for management of type 3 Cooney syndrome. Right. So let me to discuss the third case. Is a 59-year-old estate worker who was stung by bees. The patient developed severe anaphylaxis and treated at local hospital and transferred to NH Kandy, where I worked as a resident physician a few years ago. Right. So he developed severe metabolic acidosis, anemia, thrombocytopenia, rhabdomyolysis, acute kidney injury. His serum creatinine was 5.5, CPK is more than 37,000. 37,000. He has hepatic injury with increased ALT and AST. Right. So next day, patient's condition is further deteriorate and develop anemia, repeated hemodialysis with optimal supportive medical and ICU care. He succumbed to his illness on the 4th day of hospitalization. Unfortunately, the patient passed away. So this is a case of giant Asian honeybee, Apis dorsata bambara bee sting, complicated with severe anaphylaxis, rhabdomyolysis, acute kidney injury, hemolytic anemia, acute hepatitis, multi-organ dysfunction syndrome. But you can see the first picture on the left-hand side is our patient. On the skin, you can see number of the sites of stings, and the picture in the center is the offending insect, giant Asian honeybee or bambara bee, and at the right-hand side you can see the nest of the bambara bee or giant Asian honeybee. So the thousands of stings, the insects are resting on the nest and on their hives. So when somebody disturbs the nest, the thousands of insects come out and attack. Right. So we went ahead and did postmortem. These are the postmortem findings. You can see the first picture is there is a hemorrhagic fluids in the pleural cavity. And the second one is you can see the lung with hemorrhages. And the third picture is you can see intestine, intersegmental hemorrhage in the intestine. And the last picture is the kidney. You can see it is swollen, and this is acute kidney injury. So how do you manage this patient? So what we need, so it's a challenge. It is a challenge for the management of patient who is coming to you with multi-organ failures, multi-organ dysfunction syndrome. So the reason is we have no studies, published data, no guidelines or protocols. Even you go to other countries, also no well-established guidelines and protocols. And we have limited data, most of the data coming from the case reports. So that is the lack of information, research data. And this is mostly what we do: supportive medical treatment, ICU care if needed. And also stabilization of the patient. Immediately we have to ABCD approach and treat to the anaphylaxis and allergic reactions as early as possible. And very important, CRRT is very useful. There are case reports. They have done CRRT because large molecular weight, the toxic substance chemicals are there in the venom, and we help to remove those chemicals. And also hemodialysis start as early if you suspect this patient's condition is deteriorating. And also hemoperfusion and plasma exchange. There are case reports published and patients recovered after this mode of treatment. Methylprednisolone also used, especially China, and guidelines, they say sometimes they use methylprednisolone, and there are case reports they use methylprednisolone and patients recovered. So we have lack of data. There are only limited published case report only for the management. Those are the modalities of treatment for the treatment of the syndrome, and there are cases who recovered after this treatment, and blood product transfusion may be useful. So let me to discuss what is the burden of disease in Sri Lanka. So I would like to say Hymenoptera sting poses significant health risk in Sri Lanka, resulting thousands of hospital admission and 15 to 30 deaths annually. And many stings occur in tea plantation, indicating a clear occupational hazard. And the severe reactions can lead to significant morbidity, with documented cases of severe allergic reactions and mass envenoming. And Hymenoptera envenoming can be considered as a neglected tropical disorder in Sri Lanka, and prompt recognition and management of systemic and severe toxic reactions are crucial to prevent life-threatening outcomes. So those are very, very important facts. And let me say a few words about epidemiological data on Hymenoptera sting. We don't have true data on this. When you search, when you trace all BHTs, so almost most of the BHT shows most bite, always most bite. We don't know what are the species, responsible species, or the type of insect. So most of the time was bite. Actually, it's not a bite, this is a sting. And so it's difficult to get very clear data from our records. So I discuss and get information from the Registrar General Office for the mortality reports, and they shows 12 to 28 deaths were reported annually in this country after beast, insects bite. Those insects sting, usually insects sting. So that can cause 12 to 28 deaths every year. Right. So you can see this picture I'm showing the annual deaths reported in Sri Lanka, data from Registrar General's office. Right. The hymenopterans are very, very important and useful insect in the ecology. So I would emphasize here, hymenopterans are very, very important and very useful insect in the ecology. Why? Because they do pollination service to the agriculture and wild plants. So whatever we eat every day, rice or whatever, so the hymenopterans are responsible for the pollination and the food production. So without hymenopterans, we can't live because we have no foods. So hymenopterans do the pollination service to the agriculture and wild plants. So one of very interesting, very important the animal in the ecology. And they produce honey, the people use as a energetic food, or even the very useful in traditional medicine as a medicine. And they help to control pest for crops, and they are members of food chain. So hymenopterans are very, very important. I'd like emphasize again in the ecology. So what we want to do, we should help conserve hymenopterans, bees, frozen, and while we safeguard ourselves from them. That I have to tell again and again. So what is the classifications of Hymenoptera? Hymenoptera mean membranous wing. They can live either solitary insects or social insects. So very important, solitary insects are not very harmful. The social insects are very harmful because the hundreds of insects they already disturb the nest and they attack. So Hymenoptera can classify it into three classes: ants or Formicidae, bees, Apidae, and wasps, Vespidae. You can see first picture on the left-hand side is ant, and middle is bee, and the right-hand side is wasp. So tell me the medically important bees in Sri Lanka. So social bees are more aggressive and do harm to the human being. So you can see the first picture on left-hand side is giant Asian honeybee or Apis dorsata, or we say Bambara bees. The all three cases I discussed earlier are due to envenoming by giant Asian honeybee. So giant honeybee, Asian honeybee or Bambara bee is the commonest honeybee which do sting and do medical problems for the human being. Right. So we have done a few studies at Deniaya and published, and 322 cases. Of them, 80 more than 80% of cases are due to giant Asian honeybee or bambara. So it's a very common cause for the stinging, the insect for the stinging. And the second picture, the middle picture, you can see domesticated Asian honeybee or Apis cerana, or that species is called uh, uh, Mimesa. Right. The third is feral dwarf honeybee or Apis florae or Dunwell bee. So those two species are not very aggressive and causing severe damage to us. This is, you can see the four photos of wasps. Those are very aggressive insects which cause significant damage after envenoming. The first picture, first, second, and third pictures, you can see three species of wasps, and they are yellow jackets. How can you identify those species? The first insect is Vespa tropica, a type of wasp, and you can see second segment of the abdomen is yellow. So that is the largest wasp reported in Sri Lanka. And we published cases, and I also studied, confirmed this is one of common wasps reported in Deniaya. We did a study there, and that is Vespa tropica. The second picture is Vespa affinis. It was not reported in our study, but a lot of case reports reported by Professor Sam Kuraratne and a lot of researchers. And Vespa affinis was reported in this country. And the third picture is Vespa mandarina, and that is we have not reported case much in this country. So you can see the alternative yellow and black bands on the abdomen. So Vespa affinis, first and second, both segments of the abdomen are yellowish in color. Right. The fourth picture on the right-hand side is Kalandurua or Ropalidia marginata. We have a lot of cases, and the case reports also published in the medical literature after stinging by the Kalandurua or Ropalidia marginata and causing severe allergic reaction. Right. So let me discuss very quickly what are the medically important ants in Sri Lanka. In Sri Lanka, 194 species of ants were reported. Of them, few species are responsible for the severe allergic reaction and the mass stinging events. So the first picture on the left-hand side is Odentomachus semilumus or Dalacadia. Everybody know what is Dalacadia. And the second picture is Tetraponia rufonigra or Hatpolea. And the picture on the right-hand side is Rhopilomaxis escherichia or Naikumbi. We know the species. And there are case reports and published by Dr. Ratnatilaka a few years ago, and even severe allergy and even death reported after and sting Odentomycosemilumus and Tetroponia rufonicra. So those are very, very medically important ant species in this country. So let me to move to this. So just discuss what is stinging. What is stinging? Stinging mechanisms of Hymenopterans. All female Hymenopterans, except queen, having this stinging apparatus at the tip of the abdomen. It was located at the tip of the abdomen. It is called stinger. And first picture on the left hand side, you can see is stinger, and it is located at the tip of the abdomen. The second picture, you can see it's a detached stinger from the insect or Hymenopterans, and it is muscular structure and with the venom gland and lancet for the used for the attack to the person. Right. So, stinging mechanism of Hymenopterans. The stinger is associated with venom gland. The mechanism is called stinging, not bite. So you know what are the animals which will do stinging in our country? So for an example, all Hymenopterans, bees, wasps, and ants do stinging. There is a separate gadget at the tip of the abdomen, stinger used for the stinging. You know, and the scorpion can do stinging. There's a special gadget at the tip of the tail, and also there are some fish species do stinging. There is a venom gland with the in the pin, and they do stinging, and jellyfish do stinging. So because they have separate gadgets for stinging. If animal use mouth parts for bites, that's called bite. So for an example, spider do bites and a lot of animals do bite, right? So this is a difference between stinging and bite. And so we have to use the term stinging for patient who's coming for the treatment for the Hymenoptera attack. So this is not wasp bite always, right? Right. So the second picture, you can see the stinger at the tip of the abdomen, right? So, what are the differences between honeybee and wasp or honeybee and ant? So, let me to say honeybee do sting and stinger detached from the body. You have seen patients come to you, ETU, emergency department. Patients come with the stinger, small gadgets in the skin. So that is stinger. So if stinger detached from the body, that is honeybee. So honeybees can do single uh, stinging only. After that, insect die. On the other hand, wasps can do multiple stings, and insect does not die because stinger does not detach from the insect's body. So this is the very interesting fundamental difference between the honeybees and wasps. So it helps to differentiate honeybees from wasps. Right. So what are the active components of Hymenoptera venom? A lot of toxic substances are there. So I discuss very important topic, the common substances, toxic substances, melatonin, phospholipase A2, hyaluronidase, mast cell degranulating proteins, and apamine are common substances located, reported in bee venom. So wasp venom contain wasp-kinine, PLA2, hyaluronidase. Those are very allergic substances. And ant venom mostly contain piperidine alkaloids. Those are very toxic and it can cause severe pain. And in addition to that, there are a lot of allergic substances, hyaluronidase, mast cell degranulating protein also they are in the ant venom. So those are common toxic substances in the different species. Right. Let me discuss clinical presentation of Hymenoptera sting. there is pain after sting, and sometimes you can see especially skin necrosis after sting, especially and sting can cause, and also especially was sting can cause the necrosis. Right. So allergic reaction is a common manifestation after sting, and urticaria, bronchospasm, angioedema, anaphylaxis, severe anaphylactic reaction. Also, Cooney syndrome is a type of allergic reactions end up with the bronchospasm due to this inflammatory cascade. And then what is mass stinging event? So very, very important. So patient can present with the allergic reaction, or on the other hand, it can present with mass stinging event. What is mass stinging event? Mass stinging event is due to direct toxic action of injected venom. So there should be significant amount of toxin in our body. So it needs exposure to more than 100 of stings. So if your patient's coming with around 100 or more than 100 stings, so there's risk of getting uh, mass stinging events causing multi-organ dysfunction syndromes, hemolytic anemias, and a lot of complications is due to mass. So number of sting is very important. So just to assess the patient, whether the patient is getting systemic envenoming. Right. So let me to discuss what are the mass stinging events or mass envenoming. So patients can present with arterial or venous thrombosis. We discussed our first case presented with the femoral arterial thrombosis of the left lower limb of our patient. And in addition to that, patient can present with acute myocardial infarction, cardiac CVA, cerebrovascular accidents, limb ischemia, retinal, bowel gangrenes, DVT, all reported after sting. And hemorrhage, uncommon. So gastrointestinal GIT hemorrhages, subarachnoid hemorrhages, pulmonary hemorrhages, and hemorrhagic stroke, all reported after sting. And sting. And what are the cardiac complications? So they can cause acute myocardial injuries, then Cooney syndrome, then cardiac arrhythmias. So hematological manifestations are not uncommon, and we can see anemia, hemolysis, DIC. Also, we published case of the MAHA after sting by bees. So it's a very not uncommon with hematological manifestation. So severe liver damage, hepatitis, well reported, and rhabdomyolysis, AKI. You can see the case I discussed. So presented with AKI rhabdomyolysis, not uncommon, and Guillain-Barré syndrome was reported. And then multi-organ dysfunctions, acute respiratory distress syndromes are all reported cases. Right. And eye injury, don't forget the large number of insects come and attack to the victims, and they directly can damage to sting in the eye. So it can end up with cataract, central retinal artery occlusions, corneal aberrations, corneal scarring are reported. Let me discuss why eye injury is very dangerous. You know, this bee venom contains hyaluronide days. So the cornea, mostly the central part of the cornea contain hyaluronic acid. So when the bee inject venom into the cornea, it that hyaluronic acid react with hyaluronidase, and severe inflammatory reactions and damage to the eye, and can cause, scarring, and a lot of damage to the eye. So if you see patients come to you with the eye injury, immediately we have to go to the eye surgeon, otherwise it end up with blindness. Right. So let me discuss management. So how can you manage? So, the first thing is to stabilize any immediate life-threatening problems, conditions. So ABCD approach, and tetanus status should be updated for after sting. And how do you remove the sting? Because our patients come to the ETU with the stinger. Some patients remove stingers where incident occurred, otherwise come with the stingers on the skin. So we have to remove the stingers. How do you remove the stingers? Very, very important, because this is the muscular structure with the venom gland, And if you squeeze the stinger, you compress the stinger, and then you inject venom into the victim's body. So you are injecting venom. So how do you remove? So how do you remove? So you can use your nail and scrape and remove the stingers. Or otherwise, you can use credit card. You can see this in picture and scrape it out. So that is the way of removing uh, stingers. So don't squeeze and take it out. So that means you compress the stinger and you inject the venom into the skin. Right. Management, local cold, simple allergic, very common thing. So cold compression, analgesics, antihistamine, and steroids are useful. And systemic allergic reactions should be detected immediately. Start adrenaline and antihistamine and other mode of treatments. You can start IV fluids and support your treatment. Systemic toxicity is the dangerous thing, difficult thing, and challenge for physicians. It is mostly supportive treatment and stabilize the patient with the ABCD approach and look for allergic reaction and treat accordingly. And carefully observe the patient and look for any complications, which mostly I discuss, and also do basic investigations and see whether there is any possibility of getting complications, and refer patients to eye surgeon immediately if corneal injuries are present, because you have to protect the eye. Otherwise, immediately they start steroids and everything just to prevent this inflammation, and they remove these foreign bodies, and very, very important. And supportive medical care and ICU care is very important. And we discuss our third case, and also the multi-organ dysfunction syndrome is the cause. Most of the cases, the death is due to multi-organ dysfunction syndrome. So need sometimes antibiotics and CRRT. Don't forget, if you think this patient needs CRRT, start CRRT just to remove the toxic substance as well as the dialysis. And also methylprednisolone we can use. There are case reports only they use methylprednisolone, and there are cases reported to methylprednisolone, and we don't have control trials on anything, but this is useful mode of treatment. And blood transfusion, hemoperfusion, plasma exchange also useful. Just think about the management of severely intoxicated patient, right? So need very early attention, early involvement, treatment, just to remove the toxic substance, as well as supportive care for the improvement of the which involve damage with the toxic substance, mass sticking event. And then we have to update tetanus state as well. How to prevent? So let's talk few words how to prevent the stings. So high risk group, we have to identify example people who involved for the jungle trapping and some occupations, something like the tea planters. So they are high risk group. So they advise them to avoid wearing bright cloth with printed flowers and use of scented materials. Right. Why? Because there are some environmental studies showed the especially bees attract to bright colors, clothes, and scented materials. So with the clothes with printed flowers. So advise them to not to use this sort of items that maybe that sort of people could be a victims of sting. And also as advised to wear long sleeves, shoes, and trousers for the protection from the Hymenoptera sting could be useful. Right. This is very important. What is Hymenoptera venom immunotherapy? This is a mode of treatment used for the prevention of severe anaphylaxis of patients who has past history of severe allergic reactions to Hymenoptera venom or sting. So how do you do it? We don't have this facility in our country, but usually it practiced in Western countries. They give subcutaneous injections of venom extract from hymenopterans slowly, weekly, over 3 to 5 years. So sensitize the patient. So in Western country, the African honeybees are very dangerous and do sting and cause severe allergy and even severe allergic reactions and even deaths were reported. So they do this, treatment method to prevent anaphylaxis or severe allergic reaction in future for patients who had history of severe allergic reactions to the Hymenoptera sting. And it's very, very effective mode of treatment and prevention of the anaphylaxis in the future. So that's 97% effective in reducing anaphylaxis in adults with previous systemic reactions. Okay, so what are the main challenges of Hymenoptera stinging in Sri Lanka? So envenoming Hymenoptera species in Sri Lanka, we don't know. So we have done few studies. We collected the specimen and sent to the zoology department, and we identified from the Nyaya for 5 species of insects which are responsible, and what are the common species of doing stinging. But this is different. That's for localized area. We did local hospital. But the whole island, these species are different and no well-organized research for the identification of the species. So we need more studies, especially by zoologists. And also epidemiology and spectrum of the disease also not well studied. So, and what are the chemical components of the antivenom? So a lot of species, ants, bee, ant species are endemic to Sri Lanka. So venom components should be different. So we have no any studies showing what are the venom components. We did a study with collaboration with the Amara and other scientists together, and we find out melatonin and hyaluronidase are main components of the bee, the giant Asian honeybee. So, but a lot of studies to do and confirm what are the toxic substance chemicals in the venom. And knowledge about Hymenoptera venom envenoming is limited. And always when you test VHT, it was by so that is not more than that. There is something to document. And lack of scientific data, guidelines, protocols also a challenge for the management of the patient. And EpiPen we use for keep with patients keep EpiPen if patient has severe allergic reactions for the any food, drug, or even sting. So it is not available now in our country, but the other countries it is available, freely not available. And when the patients keep with this, keep the EpiPen, and if patient develop the severe allergy, they themselves start injection. Otherwise, the time is very important, crucial factor, because that transferable that period will kill the patient. Right. So then, when immunotherapy for adults or with the children, we don't have. So it needs venom immunotherapy to prevent the anaphylaxis of patient who has history of severe allergic reactions. Right. So let me to discuss and come to the end. So what are the key messages, key takeaways? Hymenoptera sting poses a significant health risk in Sri Lanka, and the severe reactions can lead to significant morbidity and mortality. Peripheral hospitals should be ready for the management of allergic reactions, because most of the patients come to the peripheral hospital. And a high index of suspicion regarding Cooney syndrome is of paramount important. Otherwise, we miss the diagnosis. So, multi-organ failure is a leading cause of death and need early recognition and intervention, and mostly supportive treatment. And finally, there is also a need for the awareness program for the community as well as medical professionals on this topic, Hymenoptera and venoming. Right, these are a few preferences, and thank you very much for your participation. And this is a small hospital where I work in Denia, and we did little Hymenoptera. Thank you very much.
Thank you very much for your insightful and very interesting lecture. I think there may be a lot of questions from the audience, and we have got some questions. Right. There is a questions is asking what is the dose of adrenaline infusion in refractory anaphylaxis? I think this may be related to
Yes,
the was by
yes,
to
that is basically
those
immunology.
things.
Yes, the dose, the if patient develop severe anaphylaxis, if blood pressure is normal, blood pressure is low, but we use the IM injections, that is zero point 0.5, that is for the anaphylaxis. But if it's a refractory adrenaline, the dose we use IV adrenaline infusion. So dose, the normal, whatever the recommended dose, the time duration we have a little bit delay if ST elevations are there. Otherwise, normal infusion dose we use for the other anaphylactic reaction management.
There are some other questions. Some people ask if patient comes with history of stings, is there when to admit to the hospital and when not to admit to the hospital? Is there any particular advice that you can give?
Yes, that's a very good question. So, if patient is having history of allergy for food or drug, asthma sort of cases, even single sting can cause severe anaphylaxis. Right. So we can't predict which patient is getting anaphylaxis or not. So very close observation needed, especially patient who is having history of allergy to the stings or even allergic rhinitis, bronchial asthma, allergic for the other foods items and so on. Drug history. Definitely we have to admit. So our recommendation is the possibility of the anaphylaxis is possible for even single sting. So better to admit and observe. We can't say we can't admit this patient and observe because there are reported cases single sting can cause severe anaphylaxis and the complications.
If you're going to observe these patients for the anaphylaxis, how long we should do it?
Yeah, usually we recommended for the 24 hours observation. And especially if your patient is coming anaphylaxis, yes, for 24 hours, we have to observe the patient. And then if the patient has no any problems, anything, no bronchospasms, blood pressure is normal. So if everything is normal, then after 24 observation, you can discharge. But if you see some sort of allergic reactions persisting, not responding to initial treatment, we have to keep the patient. So that is for the allergic management, anaphylaxis management. But if your patient is coming to you with more than 100 stings, significant number of stings, so patient is a risk patient for the multi-organ dysfunction and lot of complications. So we observe 48 hours and doing all basic investigations and see whether any abnormalities are there. So we have to observe patient at least 48 hours.
There is other question. There are any measures that we can take as first aid to prevent the complication following mass stings until they reach medical care. Is there anything we can do as a first aid
First aid,
before
right?
patients
So
come to the
basically, first
hospital?
thing is, yes, any patients come to us with the sting. So first thing is we have to remove the stingers. So the method discuss the use how to remove the stingers because stinger contain venom and even it detached from the insect body, it continuously deliver the venom. So we have to remove it. So that's the first thing. And also so you know that the immediate allergic reaction is to keep EpiPen at home. So it's not available here. So idea is we have to rush patient to the hospital because of anaphylactic reaction we can't manage at home. So immediately send patient to the hospital and that is what we can do. The treatment for the anaphylaxis is adrenaline. So EpiPen should be at home if there's a risk cases are there. So stingers can remove in between, but we have to send patient to the hospital because anaphylaxis management is adrenaline. No?
Yes. There is another question. When a patient presented with ST elevation in ECG following wasp sting with anaphylaxis,
Mm.
is that recommended to thrombolize the patient, TNK and or enoxaparin?
Yes,
Whether it
yes. Basically, you can see the ECG. If it is generalized involved, anyway, first thing is treat for the allergic reactions, right? So then repeatedly see the ECG. And if you see the ECG changes disappear, that is spasm and responded to allergic treatment. So if there is no response, if there's a particular territory of the coronary artery involved, right, inferior or in anterior or anterior descending artery, so then you can see the ECG changes confined to that particular area. and it is indicating, so maybe spasm, maybe ruptured plaque, maybe thrombus. So thrombosis is possible. So there is indication for the thrombolysis. Generally, they say start activate ACS protocol, myocardial protocol, if it is depending on the ECG changes. And also most of the things where stent patient come to you, and it could be stent thrombus. So we have to remove the stent, or we have to, aspirate the thrombus. So it needs definitely support from the cardiologist. We should start the protocol, ACS protocol.
There is another interesting question. How can we clinically differentiate Kuhn type 1 and type 2 clinically or through ECG findings?
It's one of the very good question. It's very difficult. We can't differentiate actually one the Kuhn wine one you can differentiate. That's what I will show in the first case. If your patient coming to you with the generalized ST elevation and changes, and most likely that is contrary spasm, and also give immediate treatment for the allergy and repeat ECG and see whether ST segment elevation disappearing. So that is type 1. If not disappearing, so persistent ST elevation should be thrombus. So we have start treatment for the acute coronary syndrome. And also better to coordinate with, the thrombus, acute MI, and also need help from the cardiology team as well.
Is there any antivenom against this venom, or what are the
No.
future perspectives?
Yes, they try it, and especially Brazil, they're trying that, but a lot of trials are everything fail. Still, the very effective antivenom is not available.
From your experience, what is more venom, whether bee or wasp stings is more venomous?
Yeah, that's what I told you. We did studies at Deniaya. We, published in the also journal. So we studied 322 stings. So more than 80%. We identified species also. Stings are then the problems are associated with the giant Asian honeybee, and we can see complications, and that's the commonest thing. The second thing is the was Vespa tropica, and also you can see the literature Vespa affinis also there are cases causing multi-organ dysfunction. So commonest organism is giant Asian honeybee. Most of the cases also bee sting, giant Asian honeybee sting is the commonest thing that we can get was sting also, but the commonest species is giant Asian honeybee or bambara bee.
Other question, they ask whether there is any specific human features that more prone to get this anaphylaxis or the complications. Are there any patient-related factors
Yes.
for the?
Yeah, basically that is because of the bronchial asthma, allergic rhinitis, eczema, and patient has history of drug allergy, food allergy, and with the past history of sting and causing allergic reactions, and that those patients are very high risk for getting anaphylactic reactions, so severe allergic reactions.
For the thrombosis also, is that the same or the MI and thrombosis?
There are no studies because I discuss mostly cases. The depend on the case reports. There are no any control trial, anything, nothing. So only few case reports, only published case reports available. So that shows that we don't have much data.
There's another question: how to treat patient with anaphylaxis and Kuhn type 2 syndrome? Decide on adrenaline.
Very good question. It's a very difficult question. So, if the patient develop anaphylactic shock, you have to save the life. So, treatment is adrenaline. So, we have to start IEM adrenaline or subcutaneous adrenaline. So, that is slowly releasing and is effective. So, IV adrenaline is very, very infusion is for the very dangerous for this case because worsening of the acute myocardial injuries. So you have to use adrenaline, definitely IM injections with the other mode of treatment you have to start. The type 2 Kuhn syndrome. but carefully, because observe worsening of the ECG, troponin sometimes you can repeat, and cardiac monitoring and see whether ST segment is disappearing, and that sort of things we have to continue monitoring. Yes.
Mhm. The interest of time, I think it's time to stop our. There may be some other questions.
Thank you very much.
I think it was very fruitful discussion, and thank you for sharing your expertise and knowledge with all members and other trainees. Thank you for all the participants and the president for giving this opportunity. Thank you very much and have a nice evening.
Thank you.